Hey, everyone. We've had a ton of questions about this podcast and how we make it. And so we wanted to let you know that we use Anchor. So Anchor is the easiest way to make your podcast. It's free. There's creation tools allow you to record and edit your podcast right from your phone or your computer. And then the best part about it for me is that Anchor distributes the podcast for you. So it can be heard on Spotify, Apple Podcasts, Google, wherever you want it to be heard. And so you can also make money from your podcast, which is awesome. They'll match you with sponsors and allow you to get paid from it. And it's really honestly everything you need for a podcast all in one place. So Brett and I, when we decided to make this podcast, we said we wanted it to be as easy as possible. And so Anchor really made us able to do that. And so we're able to record right from our phones, upload it from our phones, and then they distribute it for you and make it seamless. So if you guys are interested in having your own podcast or you want to learn more, download the free Anchor app or go to anchor.fm to get started. What's up, everyone? Welcome to another episode of the Excel Education Show. I'm your co-host, Taylor Premer, along with Brett Winchester, and today we're excited to have another Clinical Savant series with Dr. Richard Ohms. So Rich has been in my life since basically I started chiropractic school, and if you haven't been around him, I'll give you a little bit of an intro. He's a wine snob, a coffee snob. He's a meathead.
Hotel snob. Not quite the coffee snob you are.
We always say that you get at least 4 or 5 snobberies in your life. And so did I miss any? Hotel, coffee, wine, food?
I just think in general, I just lean that way. So it doesn't matter. It could be rehab. I feel like the rehab that I get into is snobby and... but I'm still learning about coffee from you. Still that you're my guy. If I'm somewhere and I don't know what's going on, I'll send you a message and you always pick right.
Well, I'm trying. But
speaking of that, what are we drinking here? We got a little Blueprint.
Yeah, so this is Blueprint. It's an Ethiopian. It's a washed Ethiopian. So yeah, it's pretty dang good.
So I would have stopped at Ethiopian, and he goes into washed. I nod and look at him as if I know exactly what that means and what effect it has on the coffee, because I want to feel involved, but I have no idea what that means.
Basically, the washed beans are, instead of the bean fermenting in the cherry for an extended period of time, usually up to a week on the concrete bed. The wash is they just wash the cherry off of it right away.
What does it typically do to the flavor?
It doesn't make it as acidic, and you get a little bit less fruit.
So I'm going to it loses the fruit too, though.
Yep.
I'm 100% sure that I'm going to use that next week in clinic, and I'm going to say that with conviction like I've known that for 10 years.
You're welcome.
You're welcome.
Well, anyway, let's get back on track. So Rich is a chiropractor at CCRC in Columbus, Ohio. He's a former strength coach, former thrower, former basically everything. His wife is much cooler than he is. Correct. And he'll admit that. And so anyway, he's been extremely influential to me in not only the weightlifting world, but then the DNS world, and then clinically. And we've spent some good time in Oregon passing our MDT credentialing exam, and we've got some stories that are maybe for a closed podcast on
that. We continuously laugh out loud about. So. Involves champagne, breaking of glasses, breaking of champagne bottles.
Yeah, and I've known Rich literally, I feel like forever. We became fast friends when he was a rep at National. He was one of those really special MPI reps that just took a club that was kind of spiraling and just absolutely blew it up. So we were taking notice of Rich even way back when. We kind of rolled out that gate course at that one facility that was just...
I don't know, was that an actual rollout, or was that you had taught that previously?
We had taught it before, but remember that building, Sarah Lee building over there?
Yeah. Well, no, so the first time, the thing that got me into MPI, and actually got me to start my love affair with Brett Winchester, was you guys did a gate course at National in an attempt to revive it. That's what Mark said.
Right.
So they bring in this really cool course. They come in and they're talking about gate and MPI, and it's this fantastic course, and I always give you credit for this. The thing that got me into MPI was Brett doing a presentation, and I remember this one slide. I'm sure he has it in his head because he's read this book a million times. In the Newman text, the kinesiology text, there's a picture of the hip, and it's the vectors of force that all the muscles of the hip have in the coronal plane. And you had this one slide up, and me, just loving mechanics, was like watching you do your thing, like this really great presentation with that like sort of slide. I was like, I'm done. This is it. And at that point, I had only sort of like played around in club a little bit, and there wasn't a lot going on in the club. And then I instantly wanted to get involved, and then so then that jumped me into MPI, and then from MPI that jumped me into DNS, and then MPI is fantastic about basically getting people exposed to lots of different great things and then teaching them how to actually integrate them. But literally, I'm not saying this because I'm on your podcast, literally your presentation doing that with that slide is the reason I got into MPI.
That's great.
That's nothing to do with Mark King, just saying that out loud.
So then
that was a joke if everyone didn't know.
We're at a DNS seminar. Rich is about to go start his practice in Columbus. So he's got the worst low back derangement you've ever seen. He is just like, he can't walk. He's just sweating profusely.
Antalgia.
It's the middle of July. It's literally 120 degrees out. Rich's AC in his car doesn't work, and he's in some junker car. And I remember sending him away that day being like, oh my God, is Rich home good? This is just a road to nowhere. I felt so bad for him.
No, it was one of the darkest moments of my life. So to finish the story here, I basically come all the way out I drive all the way out. So I just started practice. I'm worried about, can I afford this? Can I get out there? I drive all the way out to St. Louis. I get here, and they didn't tell us that collage wasn't coming. So I drove all the way out just to see collage. I knew I had jacked my back up. That's all previous track and field stuff. And I was like, okay, I got to do this. I got to see collage. I drive all the way out here, and then they're like, oh, yeah, he's not coming. And I was like, that would have been great to know. So then Martina Jetskova, she did an amazing job and loved that girl to death and learned a ton, but collage wasn't here. So we end up doing this
spider crawl.
The spider crawl, it like treats scoliosis, and I went from like dysfunctional to totally fucked up. So can I swear on that?
Yeah.
Okay.
Oh yeah.
Totally fucked up. Antalgic. I had Robert Lardner do a neuro exam on me because I was that worried. And we get done with the class, and then I drive home, and it's like July. I'm on 70. And I get stuck in traffic for 3 hours. Now, if you've ever been fortunate like me and had a car that doesn't have air conditioning, you need to be moving to have any kind of problem. So I'm sitting, right? So I am provoked by sitting. I can feel the pain, the sciatica radiating into my hip, down into my leg, and peripheralize it. And I'm just sitting there, and I look up in the mirror, and I can see sweat pouring off my face. And I was stuck in traffic going 0 to 5 miles an hour for 3 hours. I'm not kidding. I'm not embellishing at all. Got home. I can still walk. I was still like DNS, and we're still friends. So,
another hilarious story Rich has is that he got his dates mixed up on a D course, and
there's a long story to that. But I have reason.
So insane.
This. Why are you bringing up literally the darkest moment? The darkest moment. Okay, all right. So this is what happened. I'm not even gonna tell the whole story.
This is military. We tear you down.
Yeah, great. It doesn't matter. It doesn't matter.
Yeah.
So the dates got fucked up. Fine. We're done. I have my reasons for this. I no longer use a dump account. An email thing for this reason. But for whatever reason, I get to go to Prague. For the first time, again, early on in practice, excited about getting certified in DNS, excited to go to Prague, excited to hang out with Brett, yada yada yada. So I get there, and I went with a good friend and huge mentor of mine, Robert Lardner. He was trusting enough to say, okay, yeah, let's just get the flights and we'll do all this. So I timed everything. So it would have been fine if it was just me. So Robert Lardner, right, comes out with me. And we're sitting in the airport, and we're probably waiting for about an hour, and one of the PTs from Prague was supposed to pick us up. So then Robert calls her. Well, she's in Sweden teaching because the seminar got moved a week back. So now we're just sitting there, and the air was not good. Robert's a very, very sort of kind individual, so he didn't punch me or whatever. But I ended up having to fly home that day, Like I just basically we got to Zuzana's house. I was there.
This is in Prague.
Yeah,
Czech Republic,
I'm in Prague. I'm in Prague for 13 hours total. I fly back. I'm trying to like get a practice going. So we throw like 12 patients back on my schedule for that week, and then I had to actually buy another ticket to fly back the following week. Fortunately, Robert been there a bunch of times, had a great time, and I didn't wreck his whole trip. But for me, it was just brutal. Anything else?
Let's get on to the upside original, because things turned up after that.
Things went up hard. So we talked about you raging sciatica and your low back pain, and then so you have this company, Athlete Enhancement, and you've been doing Project Trunk Stability, and you did how many weeks of it?
I don't know where we're at now. I think we're 44, 45 weeks in. I've wanted to do this forever. And it was basically a COVID project where every Monday for an entire year, I release a different exercise to work on trunk stability. And they're short videos. They're 20 seconds to maybe 40 seconds of just like some pretty simple narration. And then I wrote, they ended up being about 800-word articles on not necessarily like just like how you perform that exercise, but actually I'll get into the anatomy or the mechanics. I might talk about whatever just was sort of like on my brain for the exercise. And so there's going to be 52 articles that are about anatomy and mechanics of trunk stability on there, and we'll finish that up I think in March.
Yeah. What are some misconceptions, do you think, in the world about trunk stability? What are people missing right now as of 2021?
So I don't think that people understand intra-abdominal pressure well. They know how to use it in a sentence. Everyone says it, but they don't fully understand what it is, which might not be a big deal, but they don't know how to create it. And I know that you two are familiar with this because DNS teaches creating and controlling intra-abdominal pressure better than anybody. And if you don't know how to do that well, that's going to affect you clinically. If you've got someone with anything, low back pain, shoulder impingement, plantar fasciitis, whatever. And it's also going to have a massive effect on performance. And so you have people that there's all these like nuances, like they'll brace and maybe they're just tightening up or cranking on their posterior chain, and maybe there's pressure in there a little bit, but they don't know how to create a stabilizing strategy that is based on intra-abdominal pressure. So that's one huge one. The other big misconception is they think that trunk work is like side bridges and just like some crunches or McGill Big 3 or whatever you just throw in at the end, and you think that that's going to actually get a high performing or result or produce a high performing trunk, and it just doesn't. Like there's a place for that on the continuum, but there needs to be a wide variety of exercises. And if you follow the Project Trunk Stability on the Athlete Enhancement YouTube page or the Athlete Enhancement Instagram, you'll see something super basic like a 3-month breathing position that we work on in DNS, all the way up to heavy front rack holds or single arm overhead lunges or whatever, or swings. You have to be incorporating all of these different components to get someone to have this high performing trunk. So that's usually just like a bunch of abs twice a week at the end of the workout, and it needs to actually be a component of every exercise that you do because you've taught them how to pressurize properly or brace properly. Maybe we can define brace in a second. And it can't just be like, a bunch of crunches, Tabata crunches at the end of the workout.
Right.
So you've kind of played in two worlds. So you're in the clinical world and you're in the strength and conditioning world. Can you talk about how that's been a benefit to you maybe in your teaching, being able to play in both those worlds? And
yeah, that's basically Athlete Enhancement, which is it's really like an education platform where I do what I call intellectual arbitrage. So I'll take information from the strength training world that I think is relevant to the medical world, and I'll take it and teach them that, and then I'll take information from the rehab medical world and then kind of teach it to performance coaches, strength coaches, or whatever. But for me, like as a benefit, it basically is the lens through which I look at every patient that walks in the door. So I'm always looking at their movement patterns and thinking that way, which I know you can get from the clinical side. MPI teaches that, FMS or SFMA. They're all this movement-based stuff or function-based stuff. But that I can't ever really take that lens off. It doesn't matter who I'm treating. And then the other thing, just practically, it's allowed me to have access to some cool athletes and work with some really great groups like Project Lift in Columbus, Ohio, because I understand the movements, I understand strength training. And then it's also fun, I talked about it yesterday in the R2P presentation, but going a little bit beyond the clinical thing and actually getting into some strength training stuff that I can do with the athletes to get them to actually take what we learn in the clinic and then apply it to their performance stuff. So those 3 reasons it's just been a ton of fun.
Mm-hmm. You have a talk later on this morning on the different things from the lumbar spine that can refer into the lower extremity. Can you kind of tease us with that, what you're going to be talking about?
Yeah, so there's basically 5 mechanisms that can produce or contribute to lower extremity pathology. The first one is a direct mechanism, and that is the lumbar spine basically produces trigger points in the lower extremity that actually produce the symptoms. An easy example would be hip, we'll say in air quotes, trochanteric bursitis. Mm-hmm. So you come in, you got some hip stuff. What it is it's the lumbar spine is having dysfunction, and you're getting trigger points in the glute minimus, glute medius, or piriformis, right? And that'll produce hip pain. I've talked about before, I look at trigger points as neurological expressions of dysfunction. So they're not independent phenomena in the muscle. As you said yesterday in your slides, and I said yesterday as well, Kolash told us that trigger points are in the brain, not in the muscle. So when you look at a trigger point, you have to think where's the dysfunction? And the lumbar spine is a massive area that produces dysfunction. So if you have problems there, you might get a trigger point in the hip. You might get something, in the gastroc, the medial head of the gastroc produces pseudomeniscus pain. Plantar fasciitis is an easy one. You can have trigger points in quadratus plantae or flexor digitorum brevis, or one that is actually not shouldn't be classified as plantar fasciitis, abductor hallucis. And if you're actually doing a detailed palpation, you're that's not plantar fasciitis, but it still gives you this heel pain. Now, I'm going a little bit too long there. So that's the first one, okay, right? It's basically lumbar spine dysfunction, production of active trigger point that produces the symptoms. Then you're going to have an indirect mechanism, and that's where you have a trigger point that's produced in a muscle, again from the lumbar dysfunction, but now it's not the radiating referral of that trigger point, it's the increased tension in that muscle that when asked to perform, it starts producing pain. A very, very simple example is going to be your rectus femoris. So if you go back and you look at Carl Levitt, who I know is a huge influence to all of us, he has these gorgeous trigger point patterns that are based on spinal dysfunction. And L3-4, the characteristic trigger point is in rectus femoris. So if you have dysfunction at L3-4, you're going to get a trigger point in your rectus femoris. Now, if it's not an active trigger point that is actively producing your patella pain, right? But it can increase the tension in the rectus femoris. So now you've turned up the gain, so to speak, on that muscle. And now when you have them squat or go up or down stairs or run, that tension goes above threshold, and now that starts producing pain. So it's a latent trigger point in that it's not actively producing symptoms into the area, and it's the tension that produces it. The third one is going to be more of an orthopedic one. So that's where, so the second one and the third one are kind of close. We have one that's a trigger point in the muscle, and then somewhere along that muscle, usually in the tendon, it's going to produce the symptoms. But then you can have the orthopedic mechanism where, again, you're going to have trigger points. Those trigger points are going to block motion of a bone. So that then when you lose the osteokinematics, the proper movement there, it's going to produce orthopedic pain. You yesterday in your talk mentioned tightness in the external rotators, and you were checking, he's laying on their back, supine hip flexion, and checking internal rotation. Well, you can get trigger points in the hip that are then going to block motion of the femur. And if the femur can't actually do all these micro movements outside of, in the case of squatting the sagittal plane, a little bit of an internal external rotation, a little bit of abduction, adduction, you actually are going to get decentration of the joint, and the one that barks back the fastest is going to be the knee. So if you have lumbar spine dysfunction, you get tightness in the actual external rotators that blocks secondary and tertiary movements of the femur, and then when you're squatting, you get a little bit more like torsional forces in the knee, and then you get this pseudo-orthopedic pain. So to fix it, you treat the lumbar spine, the trigger points go away, the femur can move the way that it's supposed to, you can preserve centration of the knee, no more orthopedic problems. The last one is going to be more posture, and that goes in, I've talked quite a bit in my presentations and in the Project Trunk Stability about what I call an extension compression stabilizing strategy. This is just a renamed thing that I learned from Collage and Yanda. So Yanda called it lower cross syndrome, sort of appreciating this very consistent neurological pattern where the spinal extensors and the hip flexors tend to become tight, and the abdominal wall and the glutes tend to become inhibited. Collage actually calls it an open scissor position. So if you looked at a patient from the side, you're looking at the sagittal plane. That's when the rib cage is elevated, bringing the diaphragm up, like the front part of the diaphragm up, and the pelvis is tilted forward. So now you have obliquity between the pelvic floor and the diaphragm. For me, I use the term extension compression stabilizing strategy to kind of highlight the forces that are used to stabilize the spine. Because I think a lot of times people completely either forget or don't fully appreciate how damaging axial forces compressing the spine can be. And when you have that neurological propensity to collapse into that extension compression stabilizing strategy, that's going to change the position of the pelvis. So in this case, the pelvis dumps forward. And if you have somebody their pelvis goes out of the neutral optimal position and it tilts forward, we always think about that coming from the lumbar spine. We have to forget when we're walking or squatting or hitting a baseball or anything, that forward tilting is actually happening from closed chain hip flexion. So now the pelvis tilts forward, it changes the orientation of the acetabulum, which shifts the range of motion for the hip available for whatever you're doing. In the case of a squat, you tilt it forward, and now instead of having, the 110, 120 degrees of hip flexion necessary to squat without a butt wink or without actual hip pain, now it's tilted forward and you're going to get increased pinching. So you can get, basically hip impingement that has nothing to do with the hip joint itself. It has to do with the orientation of the pelvis that is tilted forward pathologically because of trunk instability. So that's the fourth one, is going to be that sort of postural component. And you can go down the chain, and I can do that with the knee, and I'll talk about later with the foot. Like hallux valgus, the pelvis tilts forward, the acetabulums orient more laterally, the femurs then, just to stay in position, end up externally rotating a little bit more. Now the foot, just to kind of stay in position with the ankle and with the knee, turns out, and now you've got increased forces producing pronation, so you can get overpronated feet. And then of course hallux valgus, because they're now toeing off medially, and it has nothing to do with the ankle, the knee, or the foot. It has to do with the fact the pelvis is out of position because the back is cranked on, and now you get a hallux valgus. The last one is going to be really from neurodynamics problem. That's the double crush syndrome. So neurodynamics problem is basically how the nerve slides and moves. And you can have, overt dysfunction where there's in the periphery. Let's say it's tarsal tunnel syndrome. Somewhere in that tarsal tunnel is on the medial side of the ankle. For the non-clinicians people, that nerve cannot slide right, and then it gives you pseudo plantar fasciitis pain or whatever. Well, you can also have subclinical lesions or compressions or something of the nerve where one site itself does not produce dysfunction, but two sites of that affecting of the nerve will produce this dysfunction. And so you can have this double crush syndrome where you've got a little bit of affect of the nerve root in the lumbar spine, and that combined with a little bit of affecting how the nerve slides, in the periphery, and now you get symptoms. So the one I'll talk about today at the symposium is Achilles tendonitis. You've got the sural nerve that runs right down the back, and then it wraps a little bit laterally on the Achilles. And if you have someone that has Achilles pain coming in and you don't do a detailed palpation and you don't know really where it is, and you don't look at the lumbar spine, you might just think it's Achilles tendonitis when in reality you need to treat the lumbar spine and you need to give them some neurodynamics. So that's the 5. So direct production of it, indirect production by the muscle being tighter, and then you get pain within that sort of musculotendinous junction. The orthopedic one, where the tight muscles block the range of motion of the bone, so you alter the osteokinematics. Then you have the postural component, and then the double crush neurodynamic component.
Noticeably omitted was the facet joint. I think like a lot of times the docs and students, and the debate rages on whether or not the facet joint's able to create sclerotogenous pain into the lower limb. Do you believe that exists? Because we've both seen papers that tells us that it can do that. Although clinically, I think we all kind of question that. Obviously, it's a hard topic to study. Probably, I would say. But do you think you didn't include it in your 5? So, do you think the facet joint is possible to refer into the lower limb, or do you think that's fresh air and illusions, as we say?
I absolutely think that the facet joint can refer, but for me, it's the facet joint is producing trigger points. So it's not a separate mechanism where the pain's there. It is literally producing trigger points. So I wholeheartedly agree with you that the facet joint can cause problems, but to me,
I'm still on the fence on. I know it can cause problems. I just don't know that
the sclerotogenous stuff.
Well, because the sclerotogenous pain referral patterns are different than the trigger point.
Well, but you can find trigger points in those patterns for sure. I know that you and I agree on this, but for me, I think that. Damn near 99% of all musculoskeletal pain, and I literally mean all, is coming from trigger points. So you can say, oh no, Rich, the disc refers. Yeah, it does, but when you actually get your hands on a patient, you can find trigger points in that area, and they might be active trigger points that are producing the symptoms, or they can be latent trigger points that are in that actual radiation referral, and when you treat the trigger points, the symptoms go away.
To our listeners out there too, Michael Shacklock in his book, he talks about an actual phenomenon called the Kingery effect, which basically means if you have a disc that's encroaching on an L4 nerve root, for example, then all the muscles that are fed by the L4 nerve root potentially can have trigger points in them as its own mechanism. And that's exactly what you're saying, but I think sometimes people don't think of it that way. They think the trigger points are separate from the actual, issue.
I think you said that really, really well. Trigger points aren't something that, you go to your massage therapist and they work on it. It is a connection. It is a direct connection for the clinician to assess the brain and the status of the nervous system. So you can get your hands on a patient and just sort of see, how are they responding to the therapy? You can identify where they're actually getting their symptoms from. So with, back to the sclerotogenous issue, I can find trigger points in there. So I don't necessarily differentiate those because I'm finding trigger points, down the hamstring or over in the hip that a lot of times I can identify as latent trigger points. So for those of you that don't know the difference, you have active trigger points are producing symptoms, whether they're provoked or not. So these are the patients that walk in, they've got a trigger point saying they're teres minor, which usually refers into the deltoid, over by the deltoid tubercle, and gives you this classic rotator cuff pain, right? So you got a trigger point there, and you're just sitting, they'll be like, oh, when I'm sitting, I feel like my shoulder's like pulling out of the socket, it hurts to drive. And that's an active trigger point. Well, you can also have latent trigger points, which is they require some sort of provocation. So that could be compression, that could be passive stretching, or that could be active contraction. And when you do that, those are the patients that either when they move, they'll get their symptoms, or to stick with the shoulder, when they're like, going through shoulder abduction, they'll get to a position and they'll twitch and move, and it's right in that position where that muscle has to fire to control the position of the humerus or to execute the movement. That trigger point fires, gives them this sort of twitch and this pain, and then they're fine for the rest of the motion. That's a latent trigger point. Then they can subclassify them into primary and secondary and lots of others, but to me, I'm just looking for active or latents. And I think a lot of times there are latent trigger points all in those areas that you can find. And when I get in there and dig around, I can poke on them and get a twitch response, or they get a little bit of radiation or referral.
Mm-hmm. That's perfect. So back to what's important, and that's wine. The three of us love wine. You and I have had kind of an ongoing conversation about the one bucket list wine that we promised each other that we will at one point have.
Sometime.
Which one is that? Which wine is that?
Well, you're talking about Screaming Eagle, right?
Yes.
Yeah. So a lot of this. For Screaming Eagle is a super famous Napa cab, and it's really just it's a bucket list because it's kind of like one of those things that lots of winos have done. It's obtrusively expensive.
Can I give some background on the wine? So
Sure.
What people swear is that this is an expensive bottle of wine. It can be anywhere between $4,000 and $5,000. But anyways, what people say is there's stories of people literally getting a loan to buy this bottle of wine because once they open it, something just mystic happens and everything turns for them in their life in a good way. So besides it, I'm sure it's an overrated wine from a taste standpoint.
Oh, I'm gonna milk that. I'm gonna have the greatest experience ever. That's gonna be the best bottle I've ever had.
There's such
It's amazing.
So what I also respect about Rich, he really treasures quality in items. Although he's a foodie and he's a wine snob, he never does it in a way that would be pretentious or anything like that. He just enjoys really good quality, and I think that's also what makes him a great clinician, a great coach, a good husband, a good friend. Those are all good qualities because you respect the quality in things.
That's actually comes from my mom, but I also think back to the snobbery, right? So that ties into the quality. Mm-hmm. Someone always asks, you just appreciate what you're doing better. Mm-hmm. So if I just sort of like coffee, I could just show up, grab some coffee and drink it, or I could learn from Taylor and study it a little bit, and then you start understanding nuances, and to me it just allows me to sort of really focus on it and really enjoy what I'm doing, whether that's coffee or that's food or that's wine or rehab or whatever. Mm-hmm. So it just, to me, it sort of elevates how much I'm enjoying the things that I'm doing.
Mm-hmm. Well, I think if you're given a high-end quality yourself, then it's good for you because then you appreciate quality because you want people to appreciate the quality of the service that you're delivering.
Yeah.
So. Absolutely. Yeah, I 100% agree. That's a really good way to put it. So we want to be the leaders in the profession and the leaders in the world, and so why not enjoy other people's expertise as well, right?
Yeah.
Fellas, this is to years of drinking wine with each other and having many, many amazing conversations. Honestly, we've had fights over wine. We've but we always wake up in the morning friends again. So
ready to go.
Anyways, thanks a lot, Rich, for just being Rich Olton.
I'm excited to watch where this Gestalt train goes. So it'll be fun to watch.
Oh, you'll be hitched on board. That's for sure. Cheers.
Coffee. Cheers. Maybe it's wine. Who knows?
Who knows?
You guys don't know what time it is.
All right. Well, Rich, thanks for sitting down with us, and I'm going to guarantee we're going to have a couple more podcasts with you. This
is too fun. Some of them will be clinically relevant. Some of them won't. Maybe.
We'll probably just do maybe a whole tasting or something like that.
Yeah.
That'd be fun.
Do a coffee tasting.
A whole podcast.
We should do a cupping.
That'd be sick on the podcast.
Cupping, not. This is a clinical podcast, so we're not talking about cupping in terms of treatment. We're talking about cupping, which is the number one way to appreciate the flavors in a coffee. It's pretty awesome.
Right. Awesome. All right. Thanks again, Rich, and good luck Monday, guys, and keep crushing it.